allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. Before we get to Abby, is there any public comment? No public comment. Abby, you're first up on the agenda. Sources of strength.
Yes, great couple of guests here with me that are coming up too. So when we get the slideshow ready, I was wondering if I share the waterfall parable really quick, if you want. I'll let you pass those out. So we'll get our presentation ready. And I will share just a parable real quick to kind of set the tone of sources of strength. So if you can imagine a great little valley with a river running through it, a quick flowing river that goes into a waterfall off the cliff. And there's a village near the waterfall. And one day, a person falls into the river, cries out for help, and is rushing towards the waterfall. One of the villagers jumps into the water and saves her and becomes a hero. The whole village is excited. And then more people are falling into the river. So the town really gets behind, what this one woman did, and they start rescuing more people. And then training more people to be rescuers and helping all of the people that are falling into the river. One day the woman starts to walk upstream. And the villagers say, wait, please don't go. We need your help. We need to keep rescuing all the people because inevitably some did fall down the waterfall. And she goes, yes, but I think there's something more we can do. We've got to get upstream. Maybe we can teach these people in the river how to swim. Maybe we could put signs up that tells them, careful, the water's rushing. Maybe we can put fence around the steep part of the bank. We've got to get upstream. And that's the whole thought behind sources of strength, is getting upstream of problem, upstream of depression for young kids. So I will let my two great helpers get started on the presentation.
And your names are?
Okay, so my name is Elise Hill. My mom's back there, so you probably know her. I've worked with her before. And this is Joshua Rose. Okay, so we're going to tell you guys a little bit about sources of strength here today, and we're so very thankful that you guys would let us come and speak to you about sources of strength.
Let's see if we can make that work. Something happened. There you go. Just have to turn it on.
Because Sources of Strength is such a large group, they made a mission statement that pretty much summarizes what Sources of Strength is about. We are Sources of Strength. We are a group of diverse students and adults from many different corners and cultures of our school and community. We believe that life has ups and downs, that all of us will go through good times and tough times. Our mission is to ensure that during the rough times, no one gets so overwhelmed or hopeless that they want to give up.
Our mission is to spread hope, health, and strength into every corner of our community. Our mission is to help students and staff turn their strengths and their supports that are all around. We are the connectors to help and strength. Our mission recognizes that our voice has a greater power, and the way we use it to break the silence when someone is struggling, and to connect them, to help them, to the help they need and deserve.
We spread hope by focusing on stories of strength rather than on stories of trauma. We know our most powerful impact comes from our personal actions, conversations, and messages that use our music, our art, our writing, our activities, our social media, our culture, and our voice. This gives life to our efforts. We are sources of strength.
Okay, so many of you probably have seen this before, some of you maybe have not, but this is our sources of strength wheel. This is like our base of sources of strength, also along with the mission. So each of these little wedges has something that everyone has, okay? And see, some of us might excel in some spots, like positive friends and mentors, but some we probably aren't the best in. So this is our sources of strength wheel.
Our first piece of pizza is I always thought it was pizza. It's family support. Family support can be our own family, parents, brothers, and sisters, but they can also be our chosen family, and they care for us and support us when we need their help or if we're stuck and in pain.
Okay, our next one is positive friends. Those are those friends that will tell you when you're doing something wrong. Those are those friends that push you up instead of trying to pull you down. Those are those friends who are always there for you. They can be older or younger than you. They can be adults or little kids. It's all basically positive friends.
For mentors, a mentor can be your parents, but they don't have to be. Mentors can be teachers at school or friends of your parents that you just really look up to. Mentors can help guide you, and if you're struggling, they can help you to find the right thing to do.
Okay, next one is healthy activities. These are those activities that take all that stress off you. These are those activities as simple as a quick walk with your dog. Maybe it's yoga, looking up at the stars. But it's those nice activities that also help your mindset.
For generosity, you might think of charity or giving things to charity. But generosity can also be helping other people. Like if you see someone sad, you could walk over to them, ask them what's wrong, and then you could make them feel better. And making them feel better can help you feel better too.
Next is spiritually. Spiritually basically gives us that sense of purpose and connection. It can be also like thankfulness, and it's like everything to us. And we all share it, and it can all be different or it could all be the same.
For physical health, it's important to stay physically fit because if we don't focus at all on our physical health, we may develop health problems in the future. So it's good to stay physically fit.
Mental health. So that's when we can get help when we're struggling. It's always in our brain. See, our brain can get really off topic when our physical self is like on top. So sometimes it gets kind of distant from each other. But you gotta make sure that you have your mental health in check, and doing that may include maybe some positive friends or supportive family. Okay, so these are some of the themes of sources of strength. So we are right now getting the word out, also known as spreading the word. We're telling everyone about this amazing thing that we've discovered. Trusted adults. Those are adults who have trained and become very trusted, and you can go to them for like anything. Like Abby over here, she went through a bunch of training. And Sources of Strength Week. That's a week we're going to do in our school. And the Thankfulness Challenge. When we go to the elementary and we're going to do a 6th grade assembly, we're going to introduce them to that Thankfulness Challenge to help them get their mind back to where it should be and maybe change a little bit about how they see themselves.
The last week of February, we're going to have a Sources of Strength Week. During this week, we'll have games and activities relating to the 8 different sources of strength that we've talked about. And it's also a good time to maybe get introduced, and if you would like, you could also help out there or see if you could join and help out in other ways.
Okay, so this is our sick room, okay? We have this wheel painted on, which is the same exact wheel that Sources of Strength has. So one of our projects will be for all the Sources of Strength members to write something that they're like in positive friends. Who's their positive friends? Or like something they excel in and why they excel in it. And we're hoping to make this super cool, and yeah, and it should be really fun. And when you're sick, you can just look at that amazing wheel and realize, hey, you're not alone. You've got all these different parts of the wheel to help you out.
We are Sources of Strength. We are a large group, and maybe this presentation, maybe you've learned a few things. Maybe these things could help you out. Are there any questions?
You say you're a large group, number-wise, about how many are involved at the present time?
Okay. So in our school, there's probably about 25 of us, if not more. And we've got a lot of leaders, such as teachers or parents that come in that also train for this. And this is spread, we're trying to get spread throughout the world. So we're just growing and we're getting more people all the time. And people are like, hey, what's Sources of Strength? And then they end up joining us. And it's so great to have them along.
Thank you.
Yeah.
Are you guys having meetings at the school where kids can come to these meetings?
Yes, we are. So we had one, I think, was it last week or 2 weeks ago? But it was on a Wednesday, and everyone that could meet after school, we just meet after school. And what we did for that one was we planned out some ideas for Sources of Strength Week. So we do have meetings, and then we also have meetings. See, we're all in different groups here, okay? We got the presentations group, the people that are doing recordings, the in-school group. And so as presentations group, we meet outside as well of that big group.
So you're bringing the younger kids into the group as well as they come through grades?
So yes, we're hoping that some of the 6th graders, when we do talk about Sources of Strength, that they'll want to try it or maybe learn more about it in 7th grade and hopefully join us, because we're always wanting to expand, get more people involved, and help people if we can.
Good.
Ken?
Get others to join with you. If you got one student that is just kind of got problems and backing off, how do you reach out to them?
So if someone's having a problem here at the school, like we can talk to them, maybe by the side, or one of our teachers that are in Sources of Strength will pull them to the side or something, and we'll just check in with them. And then maybe we'll tell them a little bit about it, ask them what they're feeling, and then we'll help connect with them, because we are the connectors. So we'll try and connect with them, and maybe they need to talk to someone about it, maybe Miss Harris, who also got the Sources of Strength thing started kind of, and we just try and push for them to get better. And we're always there to support them through the way.
To be a buddy.
Yeah.
Well, enthusiasm is contagious, and I admire your enthusiasm. So
Yes, great
best
presentation.
wishes with your Sources of Strength.
Mhm.
Thank you guys.
Good, thank you.
Thank you very much.
Oh, we can all go home now. Okay. Excellent. So we're at the consent agenda. Did everybody have a chance to go over the minutes?
You look like you did very much in my absence.
I just didn't document it very well.
Okay.
I so move we accept the consent agenda.
Also second.
Moved and seconded to accept the consent agenda as presented. All those in favor?
Aye.
Passes unanimously. Except we didn't have a
Do we have a March calendar?
There was no March calendar in there, so.
I do have one from today.
We'll get that one here in a second.
I have
Okay.
one.
You have it?
Yeah.
Why don't we go ahead and pass it around?
I can do that.
Okay.
Everyone met Susie so far?
I have.
Yes.
I just did. Now I'll get back.
She's here from Florida, so congratulations to coming to the entertainment capital of the Pacific Northwest. Okay. Item 5, Ed, you're on deck.
No presentation, should be.
We'll do the financial report first.
Probably February.
Need me to think what it is February.
February is this February.
See, you were down
So the
two.
financial
So
report.
It's February.
if you do call me,
1 second, there. Nope, it's wrong one. Nope, I don't know what that is.
Start without your dad. It sounds like my day.
How do you make it go away?
I don't know. Never seen that before.
This is a new light show.
Confirm and start browsing.
There we go.
That's the wrong one.
do you have your email?
No, you've already sent, it's there. I'll put it there.
Okay.
The presentation?
Yes.
Yes, I can. Yeah, I gotta take it for each.
I would read
Yeah.
this one.
16.
Perfect, it's open for me, that's not. So I'll keep going.
Thank you.
We're still getting acclimated.
So this is a financial report for Lake Health District for December 2021. And there we go. So we start off with patient count. For acute in 2022, there was 302, which is an increase of 48 over the previous year. Clinics 2022 is 2001, which is about 106 more than last year. Most of that is due to C clinic and symptomatic patients that came in. They were able to see quite a few more. Outpatient services was at 5,264. It's a decrease of 603. 700 of those were labs. So that's the decrease. There was outpatient laboratory tests. Overall, for the month of December, we had 7,567 visits, which is a decrease of 449. A lot of that is just the outpatient laboratory. All right. Gross patient charges for December was 4.26 million, an increase of 510 over last December. I think that's good that the production is up and staying steady. Next slide. Collections for December it was 2.8 million, an increase over last December of 711. And I'm going to kind of dwell back more into AR as we go through the slide presentation. So next slide. Days cash on hand. You see there's a 17-day difference. 72 for December. Why is that, Ed? The biggest difference is there were 3 payrolls ran in December. December 3rd for the expense incurred in November, December 17th, and then December 31st. So the upside to that is in January, our restricted funds that don't count here will become unrestricted because they forgave most of the PPP loan. So So you'll see it go back over 100 in January.
We also paid out the bonuses in December.
Yes. Yes, and that was all part of it. The good part though is, go to the next slide. And this one doesn't really show it as well, but I'm gonna walk through it. That gross of 4.26 gross revenue less revenue deductions of the 1.295. I know everybody gets a little antsy around that. It should be noted that 942,000 of that was contractual adjustments. We tweaked our processes a little bit. And when they actually post the payment to the system, they're doing the adjustment, contractual adjustment right then and there. Instead of previously, which is not wrong, it's just a different way, they were doing it back here in billing. So you wouldn't see that adjustment till the following month. So now it's at time of payment, you know.
So you kind of doubled up this month, is what you're saying?
Just improve. There's more there than there normally would be.
Okay.
But definitely, just verifying that we're within our limits, I guess. When we post the payment, we want to know right away, what our true revenue number is. So, all right. So that's what that big revenue deduction is. The less expense of 3.4 million, less 70,000 in non-operating revenue expense resulted in a deficit of 435. Now, the reason we usually focus more on the year to date, and if you look up at the December on the wages and benefits line, at least we're accounting for it correctly and accruing it properly, because you don't see that third payroll there, So the cost of that payroll that occurred on December 3rd is actually captured in November. So we did that part right. But it still is $1 million that goes out the door in the same month. So when you see that $1 million drop in the balance sheet of the 71 days in cash on hand, that's it. So overall, year to date, total revenue at 18.4 million, less operating expenses at 20 million. And then you see the plus 1.3, which actually reduces it. So a year-to-date deficit of 229, where we're close with the budget, but we have a lot of work to do. Next slide. Here's the best part. I know it's never a good thing to talk like this, but our deficit in an era of COVID, as much as we throw at it, it's still, if you look at November and December, year over year, we're in a better position by, I want to say 800,000, give or take. It's when we do our debt covenants, and our debt ratio went from like 1.05 to 4 now, because those 2 bad months of November and December of last year fall off the page. So keeps the lenders happy. Next slide. Oh, so this is where I'm kind of taking a deeper dive into collections. Year over year, I tried to do a comparison and trend analysis here between 2021 and 2022. The difference is essentially 2.5 million, or about 432 extra per month. Still not at our full potential, but at least going in the right direction. I know we had a 5% fee increase, so that number 19.23 increase is really, offset by the 5% increase, so it's about 15%. So, or 14.5. Next slide. And then this is where you see the hit to the cash for that third payroll, unrestricted cash. And what you'll see in the next month is a huge gallop upwards when that PPP is forgiven, so in January. Next slide. More on the AR project, the HRG over 90. Just to break it down really quick, the facility is basically our stuff that we have to do something for them to process it. HRG, that's their inventory of what they have and haven't processed yet. The insurance is what we actually sent to insurance and collect on. So overall, it's about 24% they had about 50% or $7 million of our AR in their cap, and they were able to collect on 25% of it. Not stellar numbers by any sense, but at the cost to the hospital, it was worth it.
Why does it show only total be 6.9 when our ARs were closer to 14?
I think they had the over 90, so that everything would be the under 90. We did give them that gift of Medicare for over 30, but they were running into the same challenges we had, and they fumbled it. So I think we do it better here in Lakeview. So hopefully, next slide. Sorry, look better on my computer screen. So this is just a breakdown of the collections, you know, in-house versus what HRG was able to accomplish. You know, they had about 48% of the total AR. But if you see our total collections month after month is, you know, we're doing about 90 in-house and you know, they're doing 10 to 15%. So I felt like for the amount of staff time it takes in-house to get after this money, it wasn't feasible to continue on. It was too much of a struggle and a fight. And then they also wanted, you know, offered to do a complete business solution at like $55 an hour per person, and that's like $100,000 a month. And with those results, I don't think it was a good idea to continue.
So you've made the determination not to continue with HRG?
Yes, because of their continued underperformance, and it's honestly it's I think what it is they're a top-notch company, and they've made me a hero at other places, but they're having the same staffing and technology problems that we're having, essentially. So
What technology problems?
different processes within our systems. The insurance verification piece, that when you first check in and you have an appointment scheduled, it goes from there all the way to the very end where you're following up on why this claim was rejected and making sure that if Don's checking them in, that he has their insurance correct and that it's verified that that's the valid card and to that valid person, and that person is the guarantor. Just making sure we dot out every I and cross every T, so that we're being thorough. Next slide. And that's all I had for this episode.
Any other questions for him on
If I could add just a couple things in support of what Ed is saying. We think when you ask about technology or software, one of the components or one of the software products that we use as part of our CERN is SSI. And when we process claims, the claims processors are going through the CERN portions of the software. When it's ready to be sent, it goes through steps before it gets to the insurance company. SSI is one of those intermediary software. Sometimes, and we've had a lot of problems where we would send it and it didn't go. It would get to SSI, so then it stopped. It wasn't getting to the insurance company. So that's been a technology problem we've been struggling with for the last 3 months, I believe. And Cerner's worked on fixing it, SSI has worked on fixing it, and sometimes it works well, and then the next day it may not work. And that's been a technology problem that, as an example, HRG suggests that we throw that whole product out and use their preferred vendor, thinking that they would have better results. What Cerner and SSI have said is, no, we'll fix it. And we've been talking about this, John and Don have been hearing us talk about that through the finance committee. But it's a sort of a stuttering response time. Sometimes it works really well. This morning or today, I think there was a stream of emails saying it's fixed, this part worked, this one didn't. How do you adjust for it? So it's a constant. Normally it should be a very smooth process. And yet we've stuttered with that. Whether it's us, whether it's SSI, whether it's Cerner, and HRG has had the exact same problem. Does that answer your question about the technology?
Pretty much. But just for the audience that's watching, our stakeholders, SSI, could you explain that?
Oh, sure, that's our electronic,
Scrubber.
yes, insurance scrubber that works, and some of the issues, even on Monday, I mean, one day you had where the facility fees dropped, but the professional doctor fees didn't drop, you know, and
What does it mean to drop?
like transmitted to the insurance carrier, or Medicare or Medicaid. And then on the back side of it is we're pulling in their, approval or denial, their electronic explanation of benefits, basically, so that we, on this end, can post that against the patient account. And the two sides of it are, and I think of some of our audience members too, work on this constantly, and, they're clearing 500 to 600 claims that get stuck in that scrubber every week, to as high as 1,200. And we're trying to, on the back side of it is we're doing about 33% electronic posting of payments, where when it's fully functional, it'll do 100%. And right now we're at about 33% electronic. The rest is manually posting in, the old fashioned way. And,
Okay, well, we're getting into the weeds here.
Yeah,
a little
I'm
bit,
sorry.
so that's okay.
Well, thanks.
Ken asked.
yeah, no, and I think of the folks here too that help us do that every day, and we want to get it to a place so that they're doing more adjudication and less little tweaking and technical data, I guess.
Is that good? Thank you, Ed. Now, we get to go to,
Leave that up still.
I'm seeing do we have the budget calendar, or you can go?
We do have, yes, we've got, let's close this and bring up the budget calendar.
Yep, sorry about that. There you go.
If you can scroll and make that so the words are larger. If you hit control, you can do this.
Other way.
That makes it easier to read off things. For older eyes,
Yeah, for all you old guys out there.
Left.
so what we need to do with this is we need to have the board approval of our budget calendar and the things that are important to take into account. These are this is a very standardized process. We've done this virtually the same way for the last 12 years that I have been here. Pardon me?
And before.
Oh, I'm
Yeah,
sure
it's
a long
legal.
time before that. So this is not a new process. The dates are designed to accommodate the current period. So what we will be doing is, if you adopt this calendar, what we will have in next board meeting are the assumptions developed and prepared. Those assumptions look at what do we think the increase in costs will be? What do we think we need to set as a budgeted rate of increase? And what that does is it gives us the tools to which we create the budget. So if we have a general sense of any new services that we're buying, any major acquisitions, or anything that would be happening in the coming year, those assumptions we're going to present to you and say, this is what our best guess is. If you agree to that or you want to modify that, from there, we go through the process of developing a budget. In May, tentatively, we will have the budget committee meeting. And then we'll go through line by line the items that we estimate not estimate, this is what we think the budget should be for 2023. 2/23. If the budget committee accepts that, then we go to the next June 2nd board meeting to approve that. If it doesn't, by law, we have to have a second meeting before that June 2nd, tentatively set for May 25th, so that we can have an approved budget. It's approved on the 2nd, gets approved on the 9th of June, and then it goes into effect July 1. We also submit all of this, we have a resolution that we present the forms and the different roles.
Charlie, where are we with budget committee members?
So as of this juncture, we have not validated all of the members are going to continue. Most have said at the last budget meeting they would be willing to serve. There have been some changes. We have enough members to accommodate our committee, but if you have other individuals that you can think of that might serve the community well by reviewing our budget, please suggest them, either to us during meetings or outside of that, and we'll approach the individual.
So we need to make a motion to approve the schedule?
Right.
Well, then I make a motion that we approve the budget schedule as proposed. Second.
Any discussion? Been moved and seconded to approve the budget as proposed. All those in favor?
Aye.
Thank you.
Okay. Thank you, Charlie.
The next part that we had in here is at the HRG contract. Now, Ed talked a little bit about how that we were unclear about the success of how well they were doing, and we struggled with this. We talked about this a fair amount. As we look at the different ability of whether it's our staff, whether we were using HRG, we engaged Whipfleet to help us with some of the CPSI claims. We've been really struggling with how do we improve our collections, because that's such a critical thing. What we came to is, as Ed said, he has not been pleased with the decision to engage HRG. They have not performed, and they also agreed that they were not performing at the level that they expected, and so we received a termination notice, so that we have severed our contractual arrangement with them. So we have not engaged in any additional agreements at this time.
Have we looked at engaging them in different ways?
We have. We are still considering that, but at this juncture, we do not have a relationship with them in terms of the contract that we have.
One of the gentlemen I met at the conference was from the Astoria, the CEO of the Astoria, and they use HRG, and I was asking him where they've been successful with them, et cetera. He said probably the main area they've been successful with them is training. They've come in and they do a lot of they've had different engagements with them at different times, but they said they've had very good luck with them helping their revenue cycle with training. That's what he said.
So one of the things that Ed and I did is we talked with the revenue cycle manager at Astoria. They have used Astoria. They were one of the references for HRG. They use CERN, and they don't use SSI. They use a different product for their scrubber, but they have used them off and on for the last 8 years.
Yeah.
So they have different roles that HRG has played with them. At one point in time, they had virtually the entire revenue cycle team was a part of HRG. And then they disengaged from that. And then they brought them in, they did some training, they've done a lot of things. Astoria has been on Cerner for 6 years.
Well, the good news he said though was 3 years in from their transition to Cerner, revenue cycle was working great.
What his revenue cycle managers,
That's what he said. It was 3 years before they really got that. But he says, feel good about Cerner. Once you get it dialed in, it does work very well.
What she said to us that corroborates that is the first 2 years were miserable. And it was an extraordinarily difficult time. So she said, we feel your pain, enjoy it. It will get better.
Who do they use as a scrubber, just to, do you know?
I do know, and I don't remember.
Let's say an Thrive.
And try,
It's either Thrive or Aquatics. I mean, I'm not.
I think maybe it was aquatics. It was.
They're at 98% payment posting electronically now, where they started where we are right now at like 30%.
So
Okay.
what it says is the troubles that we are having are challenging, but they're not unique just to us. And it's not because we don't have good people, we have great people. It's not that we don't have a good software system, we do have a good software system. We're just not hitting on all cylinders. And we gotta move faster. And that's the bottom line.
Right.
Anything else we could add on that? But I wanted you to know that the HRG agreement relationship is not in existence at this point.
Was there any penalties for cutting the agreement?
I beg your pardon?
Was there any penalties for curtailing?
It's they hang out for another 2 months, and actually do analytics and whatnot, and anything that they've sent, they still are owed the 4 or 5% it ends up being, but we get the cash, so that's the best part.
Thank you, Ed. Okay, now we get to move on to the Goose Lake Medical Services.
There we go. So Lakeview Gardens for P&L revenue was 218, expenses 455, and resulted in a deficit of 237. And you see that other expense line, the Fed tax at 42,123. That's a big driving factor. The other thing is Charlie's tasked me with doing some more analytics as far as.
I'm not seeing where you're seeing that tax.
Oh, I'm sorry, it's in the yellow. I wasn't sure if that was a good.
Oh, it's not written there, it's just, that's what the other expense is.
Yeah, and you'll see it
Okay.
throughout the course, and that's what.
That's a
pains
big
me.
hit, yeah.
It's $150,000 a year.
For the tax. Doesn't make sense, but
No.
somehow they give it back to us through their revenue sharing, and it's a screwy deal.
I wish we were, if I could wish for anything, I'd love it that we get paid the way they do in California for long-term care. So in California, if you're a critical access hospital and have long-term care attached to the facility, it's cost-based reimbursement. It would make a significant difference. However, we're not in California.
What does it need at our state legislature to change it?
I think the state legislature is working on all sorts of other problems right now.
All right, next one is Lake Health Medical. Right here, so for December, they had revenue of 40, expenses were 31, which resulted in a surplus of 8,400 and 52,000 for the year. And he's got a lot of stuff going on with them, they're really getting after it, and they have some new projects they're starting, so.
Quentin told me that he thinks that January you'll be quite pleased with the revenue.
That's all I had.
Okay. Any other questions? No? Okay. Medical staff update, Dr. Chang is not here.
So Dr. Chang is not here because in part of 2 reasons. Number one, when I asked that we change the date, his schedule, times that he would be here versus elsewhere as a surgeon, got screwed up. He would have been here otherwise. And the other part was that last week he was ill, so wasn't able to be here. As a consequence, not because of that, we did not have any recommended changes for credentialing. We will have for next month.
Okay. Thank you. Okay, EHA. Mr. Shine, you're up.
Oh, Well, I just got back from my very first American Hospital Association Rural Health Conference. I kind of felt like a little kid drinking out of a fire hose sometimes, but no, it was very good, and I would encourage any other board members that haven't been to consider it. It was interesting in that it's rural hospitals all over the United States. And I guess it's good to know that some of the challenges that we're having are being replicated all across the country. Those being, COVID fatigue, and staff shortages, the high cost of travelers. The pain and the challenges that we're having here in Lakeview are being felt all across the nation. There's a common theme that hospitals all across the nation are spending more on travelers in the last few months than they ever have in the history of ever. It's one of the biggest challenges in healthcare today is staffing and that. But there was also some very interesting things too. One of the sessions was about they call it paramedicine, and what that is there's a hospital in Ohio that's working with Medicare to changing the role of their paramedics so that, I didn't know this, but to get paid by Medicare when you send an ambulance out, if you don't bring them to the emergency room, you can't bill them. So they do a lot of calls, they get called, and by the time they get there, the person changes their mind or they don't want to go or for whatever reason. And so there's kind of a bad incentive that is, if you haul them to the emergency room, whether they need it or not, you get paid. If you don't, you get paid nothing. But they work with the emergency room physician to does this person need to go? There's a communication that they're doing there, and also they're doing a lot of well checks. And then one of the things, the challenges of hospitals, and I think the way Medicare bills, it's if you have a high percent of people who are discharged from the hospital that get readmitted within a week or two, it goes against your payments and it's a big challenge. And so one of the things that they do with their paramedics, and this is being paid for by the insurance companies, and is they're doing follow-ups within a few days after people are discharged, especially if it's someone that has a new problem, like they just got diagnosed with diabetes, to show them how to check their blood alcohol or not blood alcohol, but their glucose levels. And, but they showed that their, whatever they call that, where you get put back in the hospital, it went to almost nothing compared to where it was. And there's just some innovative programs that are being done that might make sense in Lakeview.
I'm glad to hear that you found that. We have certainly looked at that. And there's an opportunity for paramedics to work in the emergency room to assist. And there's just a variety of different things that we can.
Yeah, it's giving a lot bigger role to the paramedics through programs that are funded that are good for both the insurance companies, good for the hospital, and good for the patients. Yeah. And they work a lot with their home health, so they're doing wellness checks, and so it just changes their role instead of just answering 911 calls. The role of the paramedic and the EMS really gets changed. So anyway, it was good. There was a lot of stuff on governance and strategy, which are what boards work on. Some very interesting speakers talking about COVID. The chair of the Bend, St. Charles, a very interesting discussion. So I found it very interesting. So, thanks for the.
Well, I would encourage if anyone else would like to go to the conference. There are several conferences the American Hospital Association puts on. This, of course, is the annual rural conference. There are leadership conferences. There are a variety of different programs. So it
was well attended by a lot of Oregon. Grand Ron's sent 20 people in the grant.
Marvelous.
Well, let us know about all the others so we can peruse it.
Absolutely.
Anything else? Thank you, John.
Yes.
Glad you could go down and get a suntan.
Providers.
Pharmacy management. Charlie, we're working away.
We've talked about this a little bit in the past. We originally signed an agreement in 2003 with AmerisourceBergen, and it was named something else at that time, called Pharmacy Healthcare Solutions. And we are the last hospital management contract that they have. We are no longer going to be a client of theirs. So they gave us official notice as of March 31st, we will be finished with that. We are in the process of employing the pharmacy staff. The impact will have relatively little on our part. We have been purchasing the inventory since the beginning. We do have to pay back the original $50,000 that Pharmacy Healthcare Solutions, AmerisourceBergen, paid to buy the initial pharmacy inventory. So we will have to pay that by the end of March to be in compliance. And then it will be part of the health district. So we were trying to see if we could resolve that with some other services, but it will end up being that. Another thing that will be happening as part of that termination, but it's our responsibility in pharmacy, we are having to change out some of our filtration system. So we have engaged an architect and now an engineering firm to look at the airflow. So there are some new regulations on, we have hoods or rooms that have high flow to when the pharmacist is preparing some of the medicines, you need to have if any of the medicine gets into the air, it has to be evacuated properly and filtered and whatnot. Rules have changed about that and some process rules. So we don't have the answer of what the cost is going to be, but it will not be cheap. So it looks like we will have to get some new air handlers as part of it. But the confidence we have with the architectural firm, they have done all the Kaiser hospitals, they've done a variety of different other bigger organizations. Everyone has to go through this that has pharmacies. So that process. And we'll let you know as it happens, but that's the nature of how things change. Any questions?
So with the AmerisourceBergen, how many employees are moving back to hospital employees?
So they have one pharmacist and then traveler pharmacists. They have 3 techs, and some are full-time, part-time, and per diem. So what
3 or 4 people?
Yeah, maybe 5 total. So what we're probably going to have to do is look to employ a second pharmacist. We're getting to the point where Teresa has been here long enough and she's accumulated the ability to get a fair amount of vacation. And with vacation plus continuing education plus meetings that she has to go to, she's gone a fair amount. And we'll probably have to, it's harder and harder to find traveler pharmacists, just like it is for any other professional physician. So it's just the nature of how the process works.
Any other questions? Okay, thank you, Charlie. Nursing report. I don't see Teresa here.
No, I'm Tori, I'm sitting in for
Okay.
Teresa today, hi.
Thank you.
Thank you.
Victoria?
Nursing report, we've continued with our struggles with staffing, as you've been hearing about the last few months and for a while probably, but recently we've hired 2 full-time nursing aides, which was a huge boost to our nursing staff. They're very much needed, and to get 2 full-time ones was a big boom. We also are using currently 7 travelers, all of which are from Klamath Falls. So that's been a huge boon to us because they're fairly local. They're very highly skilled, and they've come into the community in the hospital and just,
These are RNs?
yes, RNs. They're fitting in very nicely, they're working hard for us, and they like it here, so hoping to woo them into staying.
Yeah.
But we'll see how that goes. In light of all the stress of COVID and the fear of impact from the Omicron variant, however, the government has provided, created a program to provide some disaster relief nursing throughout the country, and we've managed to acquire 8 nurses from FEMA to help us with our current staffing situations. And so what we have right now is long-term care has 4 nurses, and the acute inpatient area of the hospital also has 4. 3 of them arrived just this morning, which was made for a hectic day, but we're very fortunate to have them.
How long will we have them?
We'll have them through March 31st. Yes, so Oregon Health Authority is coordinating the disbursement of those nurses based on what each hospital is requesting. We originally requested 13, but the 8 we've got, I think, will provide us the relief we need. Our biggest impact here has been with staffing. We have some nursing staff out on medical leave unrelated to COVID, but we've also had a little run of COVID among the staff that have caused absences that we need to make up for. So these nurses coming in have helped boost our staffing so that those deficits aren't as taxing on the regular staff. They aren't being as stressed as they could have been had we not had anyone to fill in. And so they have been a blessing in the last few weeks.
So our census is up in the acute area?
I'd say our average census, I would say on a day-to-day basis from what I see is 12 to 15 probably. We've increased the number of swing bed patients, the kind of skilled nursing patients we care for. We used to take up to 7 and now we're taking up to 10. So that helps with our census. And our inpatient census has increased as well. Not so much due to COVID, but for other reasons. It's harder to find beds, especially for some cardiac patients in other hospitals that are fuller. So we're having to care for people that otherwise might have been transferred.
Okay.
On visiting nurses, what do we find accommodations for them when they're off duty?
They're a travel company. They're managed through a huge umbrella travel company, and then smaller companies kind of ferret them out. But those companies are responsible for finding accommodations for them. So right now they're all at the Best Western, keeping Best Western running. What other questions do you have? Anything?
Any other questions?
All right.
I see there's something with the cardiac rehab.
Yes,
Oh.
yes, Kim is here actually.
Did you want to say
speak to that?
anything?
Yeah.
Yes, we had talked a little bit about rehab the last meeting, so I just wanted to invite everyone to come to the open house. Next week is cardiac rehab week, so we're gonna celebrate that with an open house, and we'll have heart-healthy snacks and heart-shaped cookies for everyone. But more importantly, it's to spread the word that we do have cardiac rehab available for our patients, as well as pulmonary rehab, which we will celebrate next month when they have pulmonary rehab week. So we'll do an open house for pulmonary rehab as well. And one thing I want to mention about that is these local physicians who are dealing with patients who have long COVID or other fatigue type illnesses, rehab is a really good alternative for these folks because it's not just to get you back on track with your health. It's also social networking. We had talked earlier about sources of strength. So, I look at rehab as a source of strength for these these type of patients with either long COVID or other fatiguing illnesses. And, you've heard that term brain fog. People that have had these long-term illnesses have trouble with that, and so our pulmonary cardiac rehab can help with that a little bit. Just as a happy note for the cardiopulmonary department, we do have one full-time staff RT, respiratory therapist, that is going to be starting in March, so that will be one less traveler that we will need. Yay! And then that's probably the most exciting news. And then we're working on some equipment. There's been some things happening in the sleep lab where we've been open long enough now that some of the equipment is starting to wear out a little bit. And with the respiratory equipment, we're looking at some purchases that will help our patients during the struggle. So I'll hope to see y'all on Monday.
Yeah,
Excellent.
thank you.
You'll have to give a map to Ken because he doesn't know where anything is located in the hospital.
And the map in different colors, please.
Thank you very much.
You're welcome.
All right. Okay, we are now down to the CEO report.
Before I start, a couple things. Just want to thank Tori for coming. Tomorrow is her birthday, so this was a little extra duty.
Happy birthday.
Thank you very much.
Yeah.
Before I speak, Rebecca, anything that you'd like to talk about from an HR standpoint?
One of my team members, Holly Fairburn, has decided to pursue other interests in the future. It's gonna take some time and then she's gonna see what else is out there. So I will be down a very important team member. That makes me sad, but it also makes me happy for her because it's time, to see what else is going on out there.
We all need a different shift in life.
Absolutely.
Holly's been a
we do.
good asset.
Yes. And I did add a new team member, Cassie Mudge, who is actually Tyson Lane's sister, our EMS director. His sister, yes. And then I think she's going to be a great addition. And Kim Callahan, who came over from Billy, is also a great addition. So, yeah, kind of exciting. And we've been worn out by all the FEMA nurses coming, but they are outstanding young women. And they've come with such enthusiasm.
Most of them from out of state, or?
Yeah, most of them are from Florida. And they come with great enthusiasm and they think it's beautiful here. And I
Maybe we
agree
can
with
talk a
them.
few of them into staying.
We're trying. I worked on one of them quite a while this morning.
They don't get a choice as to where they're assigned. They're just told you're going to Lakeview.
Yeah.
And so they land here, but they have so much grace and they
Yes.
really are enthusiastic and they really like it here.
Yes,
That's
very
great.
kind, enthusiastic young women.
Well, I made sure that we had a nice winter. So that
Right.
Yes, you did.
Ken?
Okay. Now, Charlie.
So just to make sure that we are clear about this nursing support, what the FEMA got involved about a year and a half ago with the state and tried to provide financial assistance. You may recall when there was a great deal of money being sent to hospitals to pay for extraordinary costs for dealing with COVID. And FEMA, who is really adept at dealing with short-term crises or specific crises, fires, earthquakes, hurricanes, they came in and said, we'd be happy to pay half of the cost. Well, most of the hospitals said, frankly, we're not interested in half, we'd like 100%. So what actually happened is Oregon Health Authority contracted with FEMA to provide this service. And Jogan is the name of the agency, the staffing agency that was contracted to deliver this service. That it's actually a Jogan contract with the Oregon Health Authority, paid for by FEMA dollars. And Jogan is based in Florida, so it's not uncommon that they would find a lot of nurses coming from there to come here. We're very fortunate to have them here. We have not requested the National Guard support. They have been providing services in lots of hospitals, but we did not ask for it. It's only recently that we started asking for the help because of the uncertainty of the surge. So I'm sure many of you have been following what is happening in the country. In Oregon, the epidemiologists have predicted that the surge of the maximum amount of COVID patients, both positive and in a hospital, they believe occurred last week. For all intents and purposes, when they, Oregon Health Authority, talk about the state, they think about the I-5 corridor. So it is anticipated that the surge will occur about 2 weeks later for us in Central Oregon, which means it could conceivably be next week that we have our peak of COVID. People that test positive or people that are admitted to the hospital. So we're uncertain of what our needs are going to be. So we felt it was prudent to ask for the assistance in advance, and their support is assured through the end of March. So it essentially gives us another 6 weeks of staffing support. We don't know what level that might be. And we've been pretty busy, as has our principal referral facility, which is St. Charles Bay. So we track and they track how busy are we and how many people, how many employees have become COVID positive and unable to work. Of course, one of the great fears that we have as a facility, I have, is if our staff all become ill, how are we going to take care of patients? So we've had a steady trickling of employees that have gotten sick. Some have gotten fairly sick and some have had very mild symptoms, very much similar to what has happened throughout the country. So even though we have one of the lowest vaccination rates by county in the entire state, our COVID experience, both inpatient and the number of people that have tested positive, has not been extraordinary. Not taking a position. I strongly believe in vaccination, but it hasn't. Apparently, the Omicron variant has impacted people that are vaccinated as well as people that are not, in almost similar levels. So we'll see what happens. Anyway, conceivably next week could be a big week for us. We'll see. We've had some changes. I'm happy to say that Susie Phildick is here. That's going to help me a great deal.
Welcome.
And she's doing great. Keep worrying that she keeps every day. Will she come back?
A long trip home.
I'm thankful that that it hasn't. She hasn't gotten frightened by it, and so we're working on that. We also had this week start. Her name is Lisa McKay. She is the new clinics director. Comes from Wisconsin. I've been working in Minneapolis at a couple of sites. So she's getting her feet wet and learning about all the issues that we have in clinics and how we manage that service.
What is her background?
Lisa has been working in clinics in a variety of different places for a number of years. Most recently, she was the clinic manager for 2 mental health facilities, 2 mental clinics in the Minneapolis area. Prior to that, she'd been with a hospital system that had clinics very much like us. They have not been rural health clinics, so she has that experience to learn. But understanding how people work together and how to work with physicians is probably the most important part. You're going to learn the intricacies of rural health clinics.
So it takes teamwork.
A lot of teamwork, very true. Scott Norby started, and he is our new security supervisor. We've had some changes in how we're handling security. As you know, I got into the security portion of our business reluctantly but felt that after all, it's not me that is here at night. It's nurses that are often not large people, and sometimes people that come in are out of control and they're big, and we need to have people protecting them. So we're continuing to make that a good and safe service for all of our employees. And of course, one of the things we do have everyone learn on that is a program called Evade. And that means you learn how to talk down people rather than confront them and have to become poor outcome. So we work very hard at remembering that we're here to take care of you. We don't have an audit date yet, sorry. We hope to let you know on that soon. There's still some back and forth and they're asking last questions. I was hoping I could tell you the specific date. We'll get that as soon as the auditors will give us that date. I wish I could change that. Ed said that we will be converting our PPP loan. So we applied back almost 2 years ago for a PPP loan through the Small Business Administration. We received $1,142,110. We put that into an account, didn't touch it, and we then asked for it to be converted from a loan to a grant. It was authorized with the exception of one component that we asked for. We appealed it, and they said no, and we appealed it again. And they were reminded us that no really means no. So one of the things that means is the part that they did not authorize as a grant is $777,000. So it's a fair amount of money. That is converted to a loan if we don't pay it back immediately at 1%. So one of the things that we are evaluating is, do we pay it back right away, or do we treat it as a loan and use that money for something else?
How many years?
Do you know the terms?
I think it's 36.
36 years?
No, I'm
The average
36.
age is over 36 years?
No, 36 months.
Oh,
Oh,
I was gonna say.
1% of 36
1%
years.
of 36 years?
That's
I think I would recommend that we take that.
Yeah. So savings account.
Yes.
We want to make sure that we're in line with our covenants with the bank. And so we don't have an answer for that at this point. But we received that notice of that it had been granted the end of January, or at the end of January, so not very long. So we will have a plan for you on that. One of the purchases that was budgeted, but I sometimes like to tell you, just so that you're aware, was a gastroscope. We use a lot of scopes when we do procedures, and over time, those scopes need to be replaced. So we spent just under $35,000 on a new gastroscope, which was a little under budget. We, I think, estimated about $40,000. So that's positive, but still a purchase. As we have been going through our clinics and evaluating the kinds of care that we're delivering, and when we're a patient-centered primary care home, we have to be recertified every couple of years. We went through and got our recertification. And there are lots of things that we have to do to prove that we are appropriately classified. There are 5 classifications and we're at level 4, so we're just shy of being the most focused patient-centered primary care home. That's important because with some of our contracts, we get paid additional monies for that, so we want to ensure that we continue that. In the process, what we found is that our clinic captures 60% of the market, if you will. And with Dr. Graham's Water Mountain Medical capturing 33%, our two clinics together capture 93% of all primary care in Lake County, or in Southern Lake County. That's a significant amount of managing the care of our community. So when we think about that, in some communities, it's not anywhere near that. And that means that people go elsewhere for their care. So say people are feeling comfortable in getting care in our clinics, both Dr. Graham's and ours. So that's a good thing too. When we think about the services, we try to stay up on the latest equipment that we can afford. You approved last summer, the acquisition, and it was approved, all finalized yesterday. We now have a 3D mammography equipment. That is the latest technology for doing mammograms. It is extraordinary when we think about what this will do for our community and our community members. Because of it going from the two-dimensional, and we have really good equipment for the mammogram services, 3D reduces callback by 40%. Now what that means is if during the exam something that's concerning is noted by the radiologist, a callback means they call the patient to come back to be checked. Now you can imagine the terrible fear that a patient has to be called back, anxiety and uncertainty. When they get called back, and they take different views and look at different ways of examining them. If they don't find anything, or it wasn't what they thought it was, yes, that's a wonderful thing, but it also makes patients concerned about why would they come back. By reducing the number of callbacks, it means that you have much more accurate information the first time. So I'm very pleased that we have this new 3D mammography equipment, and that we've been approved for all of that as of yesterday.
Great.
So very exciting. I was last Friday, and I thank you for moving the board meeting to tonight. Last Friday I was at a board meeting for the CCO. There are a lot of things that are changing in our CCO structure. It's become a very big business, and we've done a lot of really good things in Eastern Oregon. So if you recall, the CCO is the contract for the Medicaid portion of the population. When we started, we were in the 30,000 population. We're at close to 70,000 right now. That's probably going to change in the next year because of some technical issues. But since we're in CCO 2.0, so the first one was what Dr. Kitzhaber as governor helped develop and negotiate with the Oregon Health Authority. That went for about 7-8 years. Now we're on the next version of that. That's why they're calling it 2.0, like it's a software update. And a larger portion of that means that we are at greater risk. The CCO is putting greater risk for the patient population onto hospitals and onto medical groups. And so because of that, we're looking at different kinds of contracting. As a hospital, we're cost-based reimbursement, but now they're asking us to go at risk so we get capitated. That means, remember, we're already capitated for a clinic service for that population.
What does that mean?
So normally, when we see a person in a clinic, we generate a bill and we get paid for it. So in a capitated format, what the actuaries, so the mathematicians that work with insurance companies. What they'll do is take the population, predict how frequently a person will go to the hospital, go to the doctor, go to the dentist, whatever the service is. And they'll predict and say, okay, for your age, your sex, you will go 3 times to the doctor, and you will have, or so many encounters. The cost of that will be $1,000. If you take that $1,000, divide it by 12 per month, and give you 1/12 every month, that is a capitated payment, a fixed amount per month. Now, what that does is it gives you the incentive. If you go that 3 times in a year, then we've been paid for that service. Hopefully you don't go every the first month and we have to wait all 12 months, 11 months to get paid. You'll space it out over time. If you go 5 times, then we lose money. If you go once, we make money. So that's what a capitated program is. It's a way of spreading out the funds.
They take the population and put a number, and you get paid that amount.
And if they come in 10 times
If
a
they
year.
come in 10 times, do that.
That's right. But when you deal with a large population, those numbers balance out. And it's statistically a very consistent way of getting paid. And it works out. And so what the CCO is now going to do is to hospital capitation. They're going to put greater risk, will be tracked on how many patients, as an example, are readmissions. And if we keep those readmissions lower, then we get an incentive dollars. If they come back more often, then we don't. And there are other factors. So I'm not going to bring all the details, I'm just telling you those are changes that we will be negotiating with them. Some of it, we don't have a lot of choice, or health authority to find.
And that capitation is just for our Medicaid population?
This is for the Medicaid population.
Moves us away from cost-based reimbursement.
What makes it kind of challenging is we are still cost-based. So it essentially gives us an incentive opportunity. If we can manage things better, then there's a carrot, rather, because we're still cost-based. If we had, their numbers were that we had 1 patient was readmitted in the last year within 30 days of when they were discharged. So if we examined that, studied that patient, and we looked at, maybe the physician thought, well, they could go home early, but if we had kept them a day longer, we wouldn't have had that readmission. There are a lot of things that go into it. If we had helped the patient when they were discharged and were at home and had somebody paying attention to things that might have caused them to be readmitted, they fell down, something else happened. We have incentives to try and manage the care of that patient outside of the normal. If they come in, we treat them, and that's the end of it. So we become much more aggressive in that process. But those are significant changes in how this business is being managed. I think that's all that I have, unless you have questions. There's a lot of things going on all the time, but any questions I could answer?
No questions? Okay, what we'll do is we'll go into executive session under ORS 192, 660, bracket 2, bracket A, personnel, bracket C, medical staff, bracket E, real estate, and bracket H, legal. And Charlie and the board will be here. We'll take a 5 minutes